we will continue with neurological disorders. So the congenital neurological disorders are things that are present at birth. So these would be the ones we're going to look at are hydrocephalus, spina bifida, cerebral palsy. So hydrocephalus, hydro means water, cephalus means head, so excessive cerebrospinal fluid accumulating and within the skull. Spina bifida is a neural tube defect where the spine doesn't close over the neural tube, or the neural tube itself doesn't close up. So there's varying degrees of severity in spina bifida. Cerebral palsy is a whole group of disorders that affect motor function. And this is because of abnormal formation of areas of the brain that do it. It's brain damage in some perinatal period, so at about the time of birth. Could be infections, could be other damages, like lack of oxygen, that kind of thing. So hydrocephalus is an excessive accumulation of cerebrospinal fluid. And what happens is this fluid takes up space and it compresses brain tissue. To have excess cerebrospinal fluid, either you are making it too quickly or reabsorbing it too slowly. But generally, there's more produced than there is reabsorbed. So this happens like natally, so around the time of birth. The sutures normally haven't closed, and the infant's head ends up looking like something out of Star Trek. Because the pressure and the space taken up by the cerebrospinal fluid expands the bones apart from one another, and the head enlarges way beyond normal size. There's two types, the communicating and the non-communicating. So the non-communicating is some sort of obstructive hydrocephalus. Communicating is a different problem. So in the non-communicating, the flow of the cerebrospinal fluid through the ventricular system is blocked someplace. So normally we have the lateral ventricles that drain into the third ventricle, then that goes through the aqueduct into the fourth ventricle, and then down the spinal column. And one of these areas is blocked. So we're making the cerebrospinal fluid at the core end, and then it's not flowing through the ventricle system and therefore accumulates. So it's some sort of a developmental abnormality. It's a defect within the neural tube. Could be a stenosis, a myelomeningeal seal, which is the meninges becoming a fluid-filled sac and pressing down on the spinal cord. Arnold-Chiari malformation is a compression where the brainstem meets the spinal cord. what happens here is the brainstem actually extends through the foramen magnum and gets constricted there. So right where the brain is extended outside of the skull, and this could happen because the occipital bone around the foramen magnum is malformed. It could be a number of different structural problems, as it were. But no matter what, these obstructions will lead to some back pressure of this cerebrospinal fluid within the ventricles of the brain, because normally it's being produced, it flows through the ventricles and down the central canal of the spinal cord and then up and is reabsorbed in the meninges. So this makes the ventricles get bigger and compresses the brain tissue and the blood vessels within the brain. The communicating is something, so the flow is correct, but there's something wrong with the reabsorption of the CSF in the subarachnoid villi. So you have to be careful because the brain tissue can be permanently damaged. In newborns, because the sutures aren't there, the skull can actually expand, and they can and so the pressure is a little bit relieved because the skull is expanded, but it has to be treated, or else you're going to have permanent brain damage. In older people, in children and adults, we're producing a lot more cerebrospinal fluid, and the pressure increases way more rapidly than it does in the neonates, and the skull can't expand. So you're probably going to get some brain damage, and it depends on the rate of the pressure increase and how long before it's treated. I actually had a patient a few years ago who, as an adult, had this happen. She had an Arnold-Chiari, but it wasn't really bad, but she started getting these headaches because intracranial pressure was going up, and when they investigated, this is what they found. So they had to put a shunt in to take the pressure away. And so there's the picture of the baby's head getting bigger. We worry that scar tissue from meningitis or from tumors or any encephalitis can cause this, because we'll get some fibrosis and then impaired absorption. So this could be communicating. So the signs and symptoms. So pupil response is sluggish. Scalp veins appear dilated because the venous drainage, because of the pressure, is impaired. We get irritable, lethargic. The sclera is visible above the pupil. High-pitched cry when moved because the movement disturbs, and it needs to be dealt with immediately, or else there will be neurological damage. CTs and MRIs are obviously useful. Surgery, you put a shunt in for the cerebrospinal fluid to go to someplace else, and often it passes right down into the peritoneal cavity. You want it to be extracranial. If there's a frank obstruction, you remove the obstruction, which is hard if it's like a malformation of the occipital bone, for instance. You won't be able to do that. The shunt is what does that. The problem with little kids is that the shunt will have to be replaced as the child grows, because if it's going down into the abdomen, the distance between the brain and the abdomen in a newborn is very, very different than in an adult. Okay, spina bifida. Spina bifida isn't necessarily one thing, but they have a group of different deficits that have some similarities. They have a developmental abnormality. So, as the spine is formed, the lamina of the spine grows together and fuse to form the spinous process. And this fails. So instead of having one spinous process, you have two sides of the lamina not fused, so that's why it's bifid. So when this happens, it could mean that it just fails to fuse and everything else is fine, or it could allow the meninges to protrude through that opening, or it could allow the meninges and the spinal cord to herniate through that opening. If that happens, then you have some pretty severe neurological impairment. So if it's just the spine, the spinous processes don't fuse, we call it spina bifida occulta. Occult means hidden, because all it is a failure of the bone to fuse. The meninges and the spinal cord are intact and nothing has happened. Oftentimes you will see a little tuft of hair growing on the skin over the site. And it's very common. You see them on radiographs all the time. Usually there's no clinical significance to it. It's just a finding that is noted. If it's almost touching and not fused, it probably has zero clinical significance. If the meninges herniates out, we call it a spina bifida meningoceal. And so what happens is the cerebrospinal fluid that's in the meninges, in the arachnoid, will push the dura mater and the arachnoid out of the space and form a little sac, a seal. When this happens, and it might actually look like it's coming through the skin in the baby, but they confirm that there's an absence of any nerve tissue within the sac, that it's just cerebrospinal fluid. If this is the case, it can be surgically corrected, and it may or may not have any clinical effect. The serious one is the myelomeningoceal. MYE refers to the spinal cord itself. So myelomeningoceal is when the spinal cord and the meninges herniate up through the space. And the spinal cord tends to not work beyond that point. Now, this normally happens in the lumbar spine. It can happen in other places too. So occulta, you'll have this little tuft of hair and this open space. The meningocele, just the meninges come through. The myelomeningocele, it pinches off the nerve and can cause a lot of damage. Most of the time, this happens with other structural defects. If we're going to end the myelomeningocele, some pretty bad scoliosis and things like that. And usually these people are in a wheelchair because their legs don't work. So what causes it? It's a combination of genetic and environmental factors. Because it runs in families. So there's an old saying that genetics loads the gun and environment pulls the trigger. Meaning that you might have a familial preponderance to something, but environmental factors cause it to happen ultimately. Some sort of combination. Folic acid was considered to be a big contributor to this, and that's one of the reasons why most pregnant women take folic acid supplements. Gestational diabetes might be doing it. Exposure to radiation can do it. We tend to want to know this and be prepared early. So ultrasound of the developing fetus and amniotic fluid analysis will do it. Amniocentesis is how we get the fluid. The meningocele and the myelomeningocele are visible, protruding sac of the spine. The deficit depends on the level of the defect and how badly the nervous tissue is impaired. Generally, sensory and motor function below the level of the herniation is impaired. So kind of the lower, the better. We treat it by surgical repair. We don't treat spina bifida occulta. And these people will probably need some sort of ongoing assistance, read wheelchair or physiotherapy, aids to walking, things like that. It kind of varies from case to case. Cerebral palsy. So this is motor impairment. Could be caused by genetic factors, mutations, abnormal formation of different brain areas, infection, hypoxia or brain damage in the perinatal period is what seems to be the more common sort of thing. Infection, hypoxia. So this happens during difficult labors. Sometimes the placenta will tear away and the baby doesn't get any oxygen during the birth, things like that. The damage occurs just before, often during or shortly after birth. So mechanical trauma, hypoxia, some sort of hemorrhage. Hypoglycemia can do it. Infection and necrosis can do it. But there's probably multiple factors. So, like I say, the ischemia caused by placental complications. So placenta primi or the placenta becoming detached during delivery. The delivery just taking too long. Vascular occlusion, so the cord gets wrapped. Hemorrhage, so a bleed, maybe from forceps delivery. Sometimes it's aspiration, just as the baby is born, and it aspirates so they can't get the first breath, that kind of thing. Metabolic abnormalities could do it, like a hypoglycemia, that kind of thing. You won't go very far wrong thinking that it's hypoxia, though. That's the common. So what does it look like? Well, there's spastic paralysis, which means that the muscles are hyperreflexic and tight, so they can't be used because they don't relax. And it's motor cortex, cortical damage will do this. There's dyskinetic disease if there's damage to cranial nerves or the basal nuclei, that kind of thing. Ataxic cerebral palsy happens when there's damage to the cerebellum. And what that is an inability for the cerebellum to make the correction. So coordination becomes very difficult, and balance becomes very difficult for the ataxic. There can be intellectual, cognitive disability, but it doesn't happen very often. Difficulty, excuse me, in communication or speech. Very common for seizure disorders to kind of overlie this. Visual hearing deficits, again, depends on the part of the brain that is damaged. So the treatment has to reflect the individual because it has to reflect the damage, but it has to be immediate. Like within minutes, if you're going to avoid serious damage. There's all kinds of stimulation things, speech therapy, exercise therapy, devices, occupational therapy are all valid forms of having these people live somewhat normal lives. And like everything else, there's a certain amount of gray area here. Often in pathology courses, to make things memorable, they show you the worst cases and they talk about the worst cases. But there's a lot of people with very mild cerebral palsy that you would hardly know, except for maybe a funny gait or something like that. I have at least 3 patients that come to mind that are functionally normal, working people. 2 of them are married and raising families, but they have a very mild amount of cerebral palsy, and it affects them gait-wise. Okay, there's chronic degenerative diseases. So this is not congenital, and this is not acute, but rather it's chronic, and usually progressive. So the big one on this list is MS, multiple sclerosis. And what this is the loss of myelination in the central nervous system, the brain and spinal cord, and to a lesser extent the cranial nerves. MS is the great mimicker. Name a symptom, and it's a symptom of MS. So there are as many symptom constellations as there are people with MS. But there's all kinds of different levels of severity, different rates of progression, from no progression to very rapid, and all kinds of different effects. But what happens is, because the myelin is lost, the conduction of the action potentials in those fibers, in those nerve fibers, is altered. So if the nerve fibers are motor, then there's altered in motor. If it's sensory, or if they're in the sympathetic or parasympathetic, that's what's affected the most. When this happens, it's not a focal lesion. It's usually patches across the nervous system and the central nervous system. And so we have little patches of demyelination. So when it starts, we have inflammation. And the oligodendrocytes that cause the myelin in the white matter part of the brain, or in the spinal cord, is damaged and lost. These things are almost indetectable because it's little local inflammatory things. But you can imagine that if the conduction of various white matter tracts is disrupted, then there's going to be a loss of coordination. There's going to be a loss of information transfer. As these areas of inflammation grow larger, and there's more demyelination, we call them plaques. They can be visualized. A place that happens is often is either in the brainstem or close to the optic nerves. So it seems to be kind of on the underside. The plaques can sometimes coalesce and become one large single plaque. And the symptoms are going to reflect what that part of the brain is in control of. Oftentimes this waxes and wanes. So the initial inflammation will subside, neural function will return to normal, and then inflammation comes back, and then there's some return. But it generally progresses that the neural degeneration becomes irreversible, and then that function is lost. Almost invariably, if there's a recurrence, it expands. Different areas of the central nervous system become affected. Now, how quickly this happens, how often it happens, varies. The severity varies. One of the things that's difficult here is when people get a diagnosis of MS, they think about the old woman that lived in their neighborhood who ended up in a wheelchair in a year, sort of thing. And they don't realize that there are lots of people walking around with MS that function pretty normally, just have these bouts. I know someone who is a Crown Counsel, and her biggest problem is that every now and then she has trouble reading, and she has to use audio things on her computer because it affects her optic nerves. but it doesn't happen very often. So she's had 2 or 3 or 4 bouts of it, but reads quite fine, is a voracious reader of novels, etc. And that seems to be about the biggest detriment that she has. Not very severe, it doesn't happen very often. Another friend of mine's wife has got pretty severe motor issues because of her MS. So it varies. It usually happens between ages 20 and 40. There's a lot of people believe that it is an autoimmune attack on the oligodendrocytes, but by no means is that confirmed. There's a thought that it could be some micronutrient, that it prevents the formation of myelin. There's some thought that it could be something to do with blood flow and losing nutrients going to the oligodendrocytes. This is fairly new research, it's 10 years or so. And it's because we are now seeing the active role oligodendrocytes actually play in directing neural transmission and neural connections, that they're not passive oligodendrocytes and astrocytes. So maybe this is it. Likely it's kind of all three. That there's some sort of a genetic component, could be immunological, probably environmental. So there's probably a predisposition and you need an environmental factor to set off the immune system. I don't know, but it does run in families. This is all over the map as to what the signs and symptoms. It's not an inclusive thing. A very common thing is diplopia, double vision, or a scotoma, but usually it's diplopia. And really what's happening here is the signals to move your eyeballs, one is delayed going to one eye and going to the other. So if you are moving your eyes laterally to the right, the right abducens nerve is demyelinated, and the left ocular motor nerve that's doing the medial, that's moving it medially, is not. The signals are going to get there at different times and the eyeballs are not going to move together, so you're going to end up with diplopia. This is important because oftentimes this is the thing that drives people to seek medical attention. Dysarthria, areas of numbness, these things, the initial parts of weakness, people tend to pass off and think, well, maybe it's going to get better. But as it progresses, then they will get it looked at. There can be a loss of coordination, bladder, bowel, sexual issues. It's kind of almost all of the above or next to none of the above. So if it's in the cerebellum, there's ataxia and tremor and loss of balance. If it's in the motor nerves, you can have weakness, paralysis. if it's in the ascending tracts, the sensory tracts, paresthesia, that kind of thing. It's difficult to diagnose because there's really no definitive test because it's individual. Everybody with MS is different. MRIs might be helpful if the plaques can be seen. And it's useful for monitoring to see if the rate of progression. There's really no definitive treatment. So it's helping people cope with the deficits is really it. So occupational therapy, that kind of thing. Every manifestation and every individual require individual attention, and it's different for each person. It provides a unique challenge to caregivers, to nurses and doctors involved, physiotherapists, occupational therapists, because what worked with the last person may not work with the next one, you know? Okay, Parkinson's disease, way more common than you think. It's a progressive degenerative disorder, and it's a problem of the motor system. It happens in the basal nuclei, and the problem is an imbalance between the neurotransmitters that excite the basal nuclei and the ones that inhibit the basal nuclei. So we have too much excitation and not enough inhibition. So what we end up is resting tremors. That's the most common thing. So this is a tremor that happens when you're not using the muscles. It also means muscular rigidity because you're stimulating this movement, so you're getting the muscles ready to move, and they're really tight. People with Parkinson's disease have difficulty initiating, and for that matter, terminating movement. So they try and try, and there's a hesitation, and then the movement happens. And because of this, postural instability is a big problem because they can't activate the postural muscles in time to maintain posture. They can't initiate those movements. And there's this rigidity that they have to overcome, let alone the tremors. A friend of mine had Parkinson's. He just recently died from complications of the Parkinson's, but he had it for many, many, many years. And what was interesting, he used to freak people out in my waiting room because he'd come in an electric wheelchair, park the wheelchair, stand up, and walk into the treatment room. Because when the meds were working, he could function reasonably well, but you never knew when they weren't going to be working. He was an avid bowler, and I went bowling with him a couple of times, and he would drive his wheelchair up to the end of the lane, stumble out of the chair, pick up the ball, try and maintain his balance. He couldn't. He would be all over the place, waving and swaying back and forth, and then he would have trouble getting the ball pulled back, and he would have trouble then moving his arm forward to initiate that. But once he got it moving, he could completely control the movement of that ball, and he would release the ball, And almost invariably he would fall down and just end up falling on the lane. And I watched him do that and roll 9 strikes in a row. And he couldn't, and he would crawl off the lane. Like, it was the most incredible thing to see, because once the movement was initiated, there was no more resting tremor, the rigidity didn't matter, and the movement was already initiated. So he could control that movement and roll the strike. But as soon as he released the ball, he couldn't recover from the loss of balance caused by releasing the ball, and he would fall down. And he would get back into his wheelchair and drive back and high-five you. It was an incredible display. I learned more about Parkinson's disease from Simon than from anybody else. And I've treated a lot of people with Parkinson's. So it's not just the little pill-rolling tremor. Now, there's primary Parkinson's disease, and they don't know what causes it, so it's idiopathic. It usually develops later in life, after the age of 60. I have a first cousin that has primary Parkinson's, and it came on when she was 62. Or you can have secondary Parkinson's because of other things: encephalitis, sports injuries, multiple concussions, vascular disease, or overdose on tranquilizers is a big thing. So early symptoms are fatigue, muscle weakness, a difficulty in facial expression, and tremors in the hand at rest, and they call it pill rolling motions. So if you put your thumb and index finger together, like you're rolling like a little piece of Kleenex into a pill, that would be what the tremor's like. And usually it's the pill rolling tremor that becomes diagnostic, that gets checked out, and then you find the other things. Again, because people think, well, I'm stressed and I'm getting older, I have fatigue, and of course I'm getting weaker, and I'm losing my flexibility because I have some arthritis. And they don't notice their own facial expression, so it's the tremor that usually does it. As it progresses, they have trouble, the tremors are in their hands and their face, and they often lick their lips and smack their lips a little bit because it's constantly moving. They get this increased rigidity and difficult initiating movements. And so movements become really slow, because if the movement goes fast, they can't stop it so well, and so they'll lose their balance. So they learn to move really slow. They have trouble maintaining their posture, so they tend to move their center of balance forward. So they stoop forward. And the other thing that they do is, as they're walking, because they're stooped forward and the center of balance is forward, it's like their feet are always trying to catch up. Right? And it becomes very difficult for complex activities, because it's hard to coordinate, to initiate and terminate movements. So here's the rigidity, the flexed knees and hips, tremor of the face, mask-like facial expression, tremors of the hands. They have trouble with inflection of the voice, so they tend to start to speak very deliberately, and they don't have much inflection at all. Joints get really stiff and sore. Often drooling's a problem because they have trouble swallowing. Blank face is a big problem. If other things can be affected, maybe not all of them, so autonomic dysfunction is reasonably common, and it's inhibiting, so urinary retention, constipation. Orthostatic hypotension, so this is lack of sympathetic. It's hard to say whether dementia develops because of it or it's concurrent with it. I don't know. The neurotransmitter involved is dopamine. And so there's been a lot of success with giving a dopamine precursor. You can't just give dopamine because then it would be too much. But levodopa is helping a lot of people. There was a movie with Robin Williams in it that about the discovery of this dopamine thing. Anticholinergic drugs, so that's acetylcholine. Physical therapy, occupational therapy for bowels and that kind of thing. And monitoring has to happen. My voice is starting to get nasal because of
talking.
Okay, the next one we're going to talk about is ALS, amyotrophic lateral sclerosis. This is Lou Gehrig's disease. Lou Gehrig was a very famous baseball player. He was on the same team as Babe Ruth. Many thought he was a better ball player than Babe Ruth. He played for the Yankees. He was called the Iron Man of sport. He had set the record for the most games played in, etc. But he wasn't the first person to get ALS. He was just the most famous person to get ALS. So that's why people call it Lou Gehrig's disease. It might have a genetic component. They really don't know what causes it. It is probably a genetic predisposition with environmental triggers. I find it interesting. It's still called Lou Gehrig's disease because Lou Gehrig was a famous baseball player. But Stephen Hawking's had it. Professor Hawking's, the great physicist, had it, but they don't call it Stephen Hawking's disease. So it's a progressive degenerative disease, and it affects the upper motor neurons. So the lower motor neurons are the ones that exit the spinal cord. Then, so the upper motor neurons are the ones in the cerebral cortex that go from the primary motor areas of the brain, which are on the lateral side of the brain, into the spinal cord, right? And then they synapse with lower motor neurons in the brain stem and the spinal cord. So all of these motor neurons are affected, but it starts usually in the upper motor on the lateral sides. It's no indication of inflammation, and cognition is unimpaired. Stephen Hawking had, well, classic. The computer spoke for him, and like he lost more and more and more motor function, but his cognition was unparalleled. So we lose these upper motor neurons in the cerebral cortex, and then we get spastic paralysis. We get hyperreflexia. So there's no inhibition. As it progresses down and gets into the lower motor neurons, it becomes a loss of muscle tone and then a loss of reflexes. Progressive muscle weakness then follows, stumbling, falling, and eventually there's a problem of the respiratory muscles become so weak that they can't breathe. Normally it speeds along quite quickly. The progression speeds along quite quickly. They don't really know how to treat it. They're looking at stem cells, they're looking at different pharmacological treatments, but there's nothing that really seems to be working. Moderate exercise, so really it's about respiratory therapy, appropriate nutrition, occupational therapy, that kind of thing, and psychological treatment, because people get really upset about it. Now, if we go back here just one, this loss of these motor neurons, it looks like it is linked to the neurotransmitter glutamate, and that's why it's not inflammatory, but the glutamate is an excitatory neurotransmitter, and excessive amounts of glutamate or problems of processing glutamate will make these not function, and then the nerves become sclerotic about it. So there is some measure of research going into looking at how glutamate is processed, and maybe treatment in the future will revolve around that. Okay, the next one is myasthenia gravis. Myasthenia gravis is an interesting disorder. In other courses, I've included this in neuromuscular disorders, rather than neurological, because it's a problem actually of the neuromuscular junction. And it's an autoimmune disorder. And what happens is we start forming antibodies that attack acetylcholine receptors. And so what happens is on the motor end plate of skeletal muscle, receptors are formed for acetylcholine that start the muscular contraction, but then they're removed by, and they're destroyed by antibodies. When that happens, the muscle can't be stimulated, and so will not contract. And so each muscle fiber, as it falls out of being able to be used, means that the whole muscle gets progressively weaker. It's a strange disease, and it's useful to demonstrate the fact that we are constantly making these receptors, and that it's not static. We don't make receptors when we make the muscle fiber and then that's it. So what happens is, if the muscle is not being stimulated, the acetylcholine receptors are not being attacked, and they are they're being produced, so you will have more of them. And then as you use the muscle and stimulate it, then the antibodies start to destroy the receptors, and you get this progressive weakness. But it comes back. So the muscles you use the most are the ones that get the weakest, and they're affected first. So it's usually the facial muscles and the ocular muscles, because you're always moving your eyes and you're always moving your face. And it's interesting, I've met people with myasthenia gravis, and what happens is, as they're speaking, the first couple of words come out okay, and then they start slurring because the muscles become weak, and they have trouble, and then they have to stop, and then they recover a little bit. They have trouble eating because they can't chew. Aspiration is a significant problem because they have trouble breathing, and they have trouble with that. So we look at it by electromyography. We see how the muscles are being stimulated. They look for the antibodies. The history and the signs and symptoms really are this muscle weakness, especially in the face and eyes. That's it. Difficulty looking at things. Speech problems. They minimize the amount of movement of the mouth, and so speech becomes very monotone. The head gets weaker, arms become weaker as they're using them. Difficult chewing, difficult swallowing. Sometimes difficult breathing. So often they get upper respiratory infections because they retain air. They have trouble. So it's treated with by making the muscles work as well as possible, and that is by not removing the acetylcholine from the synapse, so that you get as much stimulation as possible. And they do that by using a drug that blocks acetylcholine esterase, which removes it. So you get some improvement at the neuromuscular junction. We use glucocorticoids, prednisone, for its immunosuppressive properties, so that we're not making the antibodies. We do plasmapheresis, which is literally taking the antibodies away from the blood. Remove the thymus so that we're not training up the lymphocytes as much. Thymectomy, I don't know how well it works, but it probably does. The people I know, it's glucocorticoids and the anticholinesterase drugs. Huntington's disease, I've mentioned once before in genetics last semester. It's an inherited disease. It's autosomal dominant. Biggest problem with it, it doesn't manifest until the person's older. So oftentimes they passed it on to their child before they realize they have it. The examples I used was Woody Guthrie, and who wrote the song "This Land Is Your Land," and was a great protest singer, folk singer. And then his son Arlo Guthrie ended up getting it, and he was a pretty famous singer in the '60s and the early '70s. His big hit was Alice's Restaurant, but that's another story. It's a problem. It's a progressive atrophy in the brain, basal ganglia, so it's kind of a little bit like Parkinson's, a little bit in the frontal cortex, so the personality changes. It's a depletion of GABA in the basal nuclei, and yeah, GABA is an inhibitory neurotransmitter. It's kind of the opposite of glutamate, and so it's kind of the opposite of what happens in ALS. And this is down more in the basal nuclei. There seems to be problems with acetylcholine in the brain, but again, they're not certain of this. Acetylcholine is very much involved with the autonomic nervous system. If it's more in the frontal cortex, we have mood swings, personality changes, restlessness. In the basal nuclei, you'll end up with these repetitive movements of arms and face. Chorea means dance-like. So it's this repetitive. It's not a tremor. It's more of this repetitive movement. We can now do DNA analysis to see if it's there. There's really nothing that's going to slow the progression, so they just treat it symptomatically. It's symptomatic relief as much as they can. This kind of leads us to dementia. And so dementia is a progressive, chronic thing. Cortical function decreases. Memory loss is usually the first thing that people see, but impaired cognitive skills, impaired thinking and judgment, learning problems, personality changes and behavioral changes are common. Now, there's a lot of causes of dementia. You know, most of them revolve around aging, so progressive vascular problems, so hardening of the arteries and such can lead to this vascular type of dementia. When my grandmother was in the home, she said, "Oh, all these people, apparently they have old-timers disease, but I think they're just a fancy word for doty." In the old days, they used to call dementia dotiness. Sometimes it can come on, be spurred on by infections. It runs in families, so there's probably a genetic component. It's probably all of the above. The one that gets the most attention is Alzheimer's disease. And this is cortical atrophy. And what happens here is there are proteins that are normally produced and then taken away that don't get taken away. And so these proteins, they're called neurofibrillary tangles, and plaques happen. And then neurons are lost by this. So we have this atrophy of the neurons in the cortex. and then we lose acetylcholine. But it's these plaques that seem to be causative. No definitive tests, and no specific cause. We're at a bit of a loss right now, but there's a lot of research going into it. It's only been recently that they've identified these tangles and plaques. So yeah, this is what they see on brain dissections. Now, it's very difficult to do a brain dissection on somebody who's alive, so that's why it's not diagnostic. But you can see the atrophy, the sulci are all wider, the gyri are narrower. You can just see the atrophy. And again, it's hard unless, well, the person's alive. Now, it may take years, but what you end up with is behavioral changes, real irritability and hostility. Mood swings, I guess, go with that. Anybody, and I know a lot of you work in old age homes and nursing homes, and you've obviously seen it. There's a loss of memory, especially short-term memory, an inability to concentrate, really poor judgment, and the decline of cognitive function. They start becoming like children again. Language becomes very simple. Eventually, there's an inability to recognize family or environmental things. Yeah, and it's progressive. At first, I think that the irritability and the hostility comes out of frustration of not being able to remember things or not being able to understand things, being overstimulated faster than they can take it in, forgetting things, losing things, it's difficult. No real treatment, except to make people as comfortable and happy as possible from a team of caregivers. But nothing seems to really be working. So there's other forms of dementia. Vascular dementia is important, common in people over 70, especially with blood pressure issues. So it's an insidious onset. Memory loss, inability to manage routines, and that kind of thing. My mother had this. Now, my mother was a very bright woman. She was a senator, and she served in Parliament until she had to retire at 75. And when she retired from the Senate, she was as sharp as she was when she was 50. But she started to have some blood pressure issues and basically hardening of the arteries. So her systolic blood pressure went up as her diastolic went down because she lost the elasticity in the elastic arteries. And so pulse pressure got bigger. And it's like her brain got enough oxygen and then not enough, then enough and not enough with each heartbeat. And it very quickly started to deteriorate, so that by the time she was 80, she had short-term memory loss. She could remember 1977 like it happened yesterday, but she couldn't remember if she ate lunch today, sort of thing. And she became very OCD, because OCD, when you have short-term memory loss, is a pretty viable way of coping with things. Like if your keys are always in the same spot, you can find your keys. And eating lunch at noon means that you don't forget to eat lunch. And so she became very OCD. And then she eventually lost the ability to even manage that. So it kind of was in stages. And it was rather insidious. We didn't really notice at about the time of her retirement party, she was starting to repeat herself a little bit, but nothing. Within 4 or 5 years, it was like you were dealing with a toddler, and it was definitely vascular dementia. There are other dementias. One of them is called Creutzfeldt-Jakob, and it's caused by a prion, which is basically the same thing as mad cow disease. They worry that it could be transmitted through contaminated blood, that kind of thing. AIDS will also give dementia, but we're not going to worry much about that. But it's later stages because it's the virus invades brain tissue, and there's other infections, sometimes tumors, because of the immunodeficiency. Mental disorders are dysfunctions of behavior and personality. They could be biochemical, they could be structural, they might be genetic, they could be environmental, probably both. The DSM, right now, I think they're working on DSM-6, this says DSM-5, is the Diagnostic and Statistical Manual of Mental Disorders. So we're going to look at schizophrenia and a few other things. So schizophrenia is a very individual thing. Loss of gray matter, so an inability for cognition. There's probably a genetic predisposition triggered by some sort of a environmental factor. Excessive amounts of dopamine secretion. Decreased blood flow to the frontal lobes, especially, so personality. Tend to be delusional, have bizarre behavior, or really flat emotions. But disorganized thought process, impaired communications, but false beliefs, ideas, delusions. So people get paranoid. They're convinced that the FBI is after them, and if they don't hide, they're not, they're things like that. They're treated with antipsychotic drugs. One of the problems is that antipsychotic drugs reduce the dopamine, which then can give Parkinson's type syndromes. It's uncomfortable, and a lot of people, especially if they have these delusions, think that it's suppressing and that the FBI is in fact going to get them, and that's why they have to. That's why they're taking the drugs, so they stop. And we'll just kind of leave it at that. Depression is very common. It's a mood disorder, so you can have. In the DSM, they call it affect disorder. So you can have unipolar affect disorder. or you can have bipolar, so you can have depression and mania. So there's genetic factors, developmental, psychosocial factors, stressors, all kinds of things. But depression is called depression because the activity in the brain is decreased. So there's decreased activity stimulated by the excitatory neurotransmitters. Serotonin and norepinephrine are the big ones. So there's something to do with serotonin reuptake maybe, and because serotonin gets recirculated. We don't know exactly why, but a lot of times serotonin reuptake inhibitors leaves the serotonin in the synapse longer, and it seems to help. Depression is not sadness per se, but it is really a loss of motivation. People tell me that they feel flat, they lose their affect, lack of energy, loss of self-esteem, lack of motivation, can become really irritable, lose libido and appetite. There's no joy in eating or sex. Probably varies between excessive amounts of sleep and insomnia. Insomnia leads to sleeping during the day, that kind of thing. We could do a whole course on depression. Treatment usually is counseling and antidepressant drugs. So we use serotonin reuptake inhibitors, norepinephrine reuptake inhibitors, tricyclic antidepressants. If it's really bad, you can use electroshock, electroconvulsive therapy. It would have to be pretty severe. Panic disorders seem to be on the rise. This is anxiety and panic. Sudden, unfounded, brief episodes of discomfort and anxiety. So that's a panic attack. If you have a lot of panic attacks, it's called panic disorder. It seems to, again, run in families. It's probably a problem of some neurotransmitters, serotonin and GABA. I guess norepinephrine as well. Episodes of intense fear without any provocation. Something sets you off. Palpitations, tachycardia, hyperventilation, sweating, nausea, smothering, difficulty to breathe. I know quite a few of my family members have panic disorder. My brother, various other people. One of the things that I find is that when they have the panic attacks, especially at first, they don't recognize them for what they are, and the symptoms all resemble cardiovascular incidents, resemble a heart attack. And so then you get worried that you're having a heart attack, which then increases the anxiety and increases and exacerbates the symptoms. So you treat with anti-anxiety agents. So slip a little pill under your tongue, and hopefully it goes away. So that's the 3 personality disorders that we're going to, or the 3 disorders we're going to talk about. The last section is spinal cord problems. So herniated discs. The disc will protrude, the nucleus pulposa will appear through the tear in the capsule. It usually is lumbosacral, usually it's the lumbar region. Sometimes it's cervical discs. when the disc herniates, it will push either onto the nerve root in the intervertebral foramen or into the vertebral foramen, and can cause a stenosis on the spinal cord. 9 times out of 10, because the thinnest part of the annulus fibrosa is posterior lateral. That's where the herniations tend to be, and will push on the nerve root. Degenerative changes, age, are predisposing to herniated disc. Obesity, because you're asking the disc to carry more weight, or some metabolic changes will make you predisposed to it, but will not give you the herniated disc. Generally, you need some sort of trauma, so a fall or something like that. Usually, if we have a herniated disc, the problem is unilateral, because it's the one nerve root. If it's large or it's posterior, you could get bilateral effects because of the spinal stenosis caused by it. Really bringing down the inflammation, heat, ice, opening up the intervertebral space and taking the pressure off the disc by traction is useful. Rest and loss of weight bearing is important. Anti-inflammatories and maybe muscle relaxants to relieve muscle spasms and pain. Therapy, I will have to add to physiotherapy and occupational therapy, chiropractic therapy. If it's really bad, you can surgically remove the lamina or remove the disc, or fuse the spine so that there's no movement happens at all there. Most herniated discs will resolve with reduced weight bearing, let it heal, traction, and a little bit of therapy and time. So that's it.